my philosophy to treating patients is both know exactly what you can and can't do. You get to decide what you want to do, but also be really clear about what you're going to deliver on. If you're not bothered every single day by that feature, you're really not ready to think about surgery. Someone who makes a good candidate is somebody who's motivated because he or she is bothered by a feature. How you set expectations. I tell everybody I can do better, but I can't do perfect. You want to make somebody look like they used to look. And you don't want to change their basic qualities that gave them. The paradigm has shifted in aesthetic surgery. You can see as patients age, sometimes they get that sunken appearance, but I have found that if you don't spread them out, then they can't bunch up, and then you get a less than desirable.
I'm gonna kick back when you fake like that.
Welcome back to Beauty Unveiled. Today we will chat with Dr. Eric Hamill. His Beverly Hills trained associate clinical professor at Baylor College of Medicine and revered expert in reconstructive and aesthetic surgery of the eyes, and a good friend. Thank you for being here.
Thanks for having me.
Yeah, for sure. If you enjoy this episode, subscribe to the show and share with your family and friends at drangela.sturm.com. So we talked a little bit last time about what you do and what that is. And so tell me your philosophy over the years, and has it changed of the way that you look at people and analyze them, and just the way that you do surgery, overall philosophy?
Yeah, well, when you first start out, you're really just trying to refine your craft. You've spent so many years, 7, 8, 9, 10 years training, learning from all your mentors. You kind of have to figure out what it is that works for you and what works well in your hands. So I feel like the first 5 to 7 years, you're sort of figuring that out, and you're starting to refine your technique, and sort of calibrating how you can get certain results for certain patients with different sorts of morphologies. Some patients have looser skin than others. Some patients have a fuller face than others. So you really just try to hone your craft, and I feel like it's like that. I feel like that's the case for most professions. You learn what you're doing, and then you get proficient at what you're doing. So I think the first 5 years you learn that, and then you learn also how to talk to patients and how to gauge what the patient's concerns are. I feel like with what we do, having that conversation with the patients. What are your goals of care? How can we meet those goals? Is one of the most important things you do. And again, I think you learn that as you're moving along in your career. So my philosophy to treating patients is both know exactly what you can and can't do. Know what you can deliver on, know what your limitations are, and then also really get good at having those conversations with the patient and saying, hey, this is what. If that's what concerns you, these are what your options are. You get to decide what you want to do, but also be really clear about what you're going to deliver on, because it's not fair to the patient if you're not clear on that. You never want to set somebody up for failure. If anything, you kind of want to underplay what you can deliver on so that they're pleasantly surprised afterward.
I agree. What about those people that say, well, do you tell me what I need?
I can't help with patients. No. That's a great question. I go through a couple of things with every single patient I talk to in consultation. And one of the first things I tell everybody is, who is ready for surgery? And what we're talking about here on this podcast, and by and large what we do here in this office, is not, it's not cancer. We don't do a whole lot of trauma in this office. These are elective surgeries that the patients want to tweak some particular feature. So I tell everybody, hey, who makes a good surgical candidate? One, someone who's bothered by a particular feature every single day. And I tell them, if you're not bothered every single day by that feature, you're really not ready to think about surgery. And then even if you are bothered by it every single day, I would never say, hey, you should have surgery. You're at the point where you could think about it. Now's the point where you could have the conversation with whoever is in your close circle at home. You guys can start to talk about it. But you're just not going to be happy if it only bothers you, one Saturday a month. It just the itch isn't strong enough to where I think you should have surgery to scratch it. So that's the first thing I tell them. And then I also tell them, someone who makes a good candidate is somebody who's motivated because he or she is bothered by a feature. If someone else is telling you, hey, you should have that feature, that again, I can't make that person happy.
Right.
It's not you who I'm trying to achieve that goal with. And then finally, I tell everybody too, and this kind of goes back to what we were saying earlier, how you set expectations. I tell everybody I can do better, but I can't do perfect.
Yeah.
I am my biggest critic, and when I look at every single case I've done, I always think, gosh, I could have done that differently, or that could have healed a little bit differently. And I think that's a healthy way to look at things, because I think that encourages growth and progression. And if you're not doing that, I think it's harder to get better.
Yeah.
But I'm pretty open and upfront with patients about that. And I know it's probably cost me a few surgeries because maybe I'm too brutally honest, but at the end of the day, I just want happy patients. And I think that's what we all want is the happy patient that's, came in with a goal and we achieved that goal, Mm-hmm. I was thinking about this the other day. I was talking to a friend of mine at Baylor, and we were just talking about why we went into medicine. And I kept on thinking, like one of the things I love is when you make somebody happy, or you do a really great surgery and both you and the patient recognize that, and then you walk out of the room and give a little fist pump. Like, 10 years I worked on that just to deliver. I'm so happy I can make that kind of a difference in somebody's life.
Yeah, it is. That's what brings us back every day. That we're like, oh, that feeling where you're like, 100%. Yeah, that was such a good job. Oh, yeah. And they're excited. And what you said, I think is so important, because I had the conversation I had with people. It's like, I need to know what your bullseye is, because I may totally hit the bullseye, but if I think it's over here and you think it's over here, I've missed it altogether. So we need to make sure, like, I'm hitting what bothers you. What about the people that are like, look at this picture on my phone. I need it. And it only bothers them when the picture's on their phone.
That's tough. Again, you kind of go back to that conversation and say, this is what we can and what we can't do. If it's a picture of him or herself, I feel like that's almost easier than someone saying, hey, I want you to make me look like this person, which is someone totally different. Like that person, I can't do that. That's not you.
Right.
But someone who brings in a picture of him or herself like 15 years ago, I mean, sometimes I actually think that helps. You can say, oh, well, you've always had a pretty full eyebrow. We don't really need to do anything like that, because that's the way you look, and that's the way you've always looked, You don't want to Kenny Rogers somebody.
Right. Nobody wants that.
Sorry, Kenny. Rest in peace. But at the same time, you want to make somebody look like they used to look, and you don't want to change their basic qualities that gave them the appearance they had when they were growing up, and what their self-image is sort of built around. Yeah.
I feel like brows, it's super important to have those pictures where you're like, okay, like you said, okay, you've always had lower brows, and so if we really raised your brows, it would look very different. And
yeah, 100%. The brows are interesting. I feel like the brow is the feature on your face that's probably most responsible for conveying your sense of emotion to other people. Your brow's low, you're angry. Your brow's high, you're surprised. And it's if you hone in on that, it's usually the central brow. So as I've gotten older and more wizened,
more birthdays.
Right. I try not to mess with the medial brow that much. Unless it's really, really low. Typically, you don't need to do anything with that. Really, it's just that. It's the tail of the brow. As that comes down, it gives you that sort of hooding on the outer side of the eye that you just can't fix with eyelid surgery alone, because that's not part of your eyelid. But again, as I've kind of gone through this, I think leave the central brow alone. If anything, just kind of what they call it a recontour of the lateral brow, a reshape of the lateral brow. It's a useful adjunct, but.
And I feel like whenever I reposition the brows kind of up and out, it helps the central brow in a more natural way than trying to lift the brow. So.
Yeah, totally. And then the other thing I noticed too is that people who've had that central brow lift who don't need it, or just way back up, who've had that central brow lift, it's really tough. Like sometimes you can have little variabilities in the height of that central brow, and that's super noticeable.
Yeah.
Because when I'm talking to somebody, 90% of the time when I'm talking to them, my focus is right here. It's either your eyes or right between your eyes. That's all I look at when I talk to somebody. I'm not really looking at your earlobe, not looking at your collarbone. It's your eyes and your glabella.
Yeah.
And so if you have just a little bit of asymmetry, it's super noticeable, which again makes me cautious going into that, because you have to set expectations and you have to make sure you don't create new problems.
Right. So what's your favorite way to raise the brow?
Yeah, I mean,
technique-wise.
Yeah, always experimenting. The best way to do it, again, is just to have a result that people, you deliver on something where no one knows that you've had surgery. So I typically like to hide the incisions behind the hairline if I can. Much easier to do that in people with a sort of a shorter forehead or like a really low hairline. Because that way you can make the incisions closer to where you're working with, and then they don't see, you don't have as much of a height and a vector to overcome to get the lift that you want.
I think it's easier too, like just physically easier.
Yeah, I agree. So I'll make the incision usually behind that lateral hairline, and then dissect down onto the deep temporalis fascia, and then sort of release everything around the bones of the eye, kind of release all those tissues, lift them up, and then when you're securing, either secure it to the deep temporalis fascia, which is sort of a soft tissue structure that's right here in that temporal fossa. Or if you're more medial to that, you can make a bone window too and just secure it there to that bone window, which I think is super effective also, yeah. And that way you have two different places where you can fixate, and then if the patient's anatomy is variable, you always have something you can secure to.
Yeah. That's the way I've gone to doing it. And I like it a lot better than I used to do, like the 5 different incisions and always use the scope. And now I don't always use the scope. It just depends on like their anatomy and how easily I can.
You can usually see everything pretty well there.
Yeah.
The thing to watch out for is just, there's a number of things to watch out for, but the sentinel vein, is right there at the lateral canthus. And even if you have like a little headlight, or if you have the help of a lighted retractor, you can see that vein as you're working there and steer clear of it if you need to. Yeah. And patients, they say it's not painful.
It's not. Yeah. It's crazy how much you do, and it's really not painful.
I haven't told my patients to take anything stronger than Tylenol in about 4 years. Yeah, so the day of the surgery, you give them plenty of local so they're comfy the day of surgery. They go home. I typically use a mixture of lidocaine and bupivacaine. So lidocaine is a short-acting local anesthetic, usually has a half-life of about 45 minutes. Then you got bupivacaine, which lasts about 4 to 6 hours. So they leave the operating room, or if we're doing it here, the procedure room. They go home, they're comfortable, typically take a full dose of Tylenol, and then that's it. I mean, there's about a 2 out of 10 uncomfortable, but it's no worse than going to the dentist. Yeah. And usually by the next day, patients don't have any issues.
They're fine.
That's what I found.
Yeah.
Even with the bone tunnels, they say no big deal.
Yeah. No, I agree. They don't really have a lot of pain with it, which is good. So it's good not contributing to the opioid crisis and overprescribing, which I feel like isn't talked about as much anymore. But I'm definitely trying to prescribe less opioids just overall, because I feel like facial surgery, it's just not painful like people think it's going to be.
Once you get through that first window, again, if you have enough local on board and the Tylenol takes the edge off, it's usually not a big deal.
Do you feel like expectation setting plays a big part in that, as far as there will be some discomfort, but it's not going to be?
Perhaps. Patients always ask me, what is it going to feel like afterward? And they ask me about the post-op pain medicines, and I do tell them in the consultation, Tylenol is all you need. Yeah. So maybe that helps. I don't consciously do it. Like, I don't make a purpose of setting expectations, because really Tylenol does.
Just does the job. What
I will tell them sometimes is, if Tylenol doesn't cover it, just to give them a plan B, take some Motrin or Advil 3 hours later. Both of those, if you take a full dose, for both of those medicines, Tylenol, acetaminophen, which is the generic name, or Advil, ibuprofen, both of the dosages that they give you when you buy it over the counter is a 6-hour window. So if you take one dose of, say, Tylenol as soon as you get home, you could take the Advil or Motrin 3 hours later, and then 3 hours after that, you can take the next round of the Tylenol. And so they always kind of have something on board. And I tell everybody, hey, just keep some Tylenol by your bedside table in case you wake up in the night and, you have a little bit of discomfort. I want you to sleep well. Sleep's super important for healing. So just pop a Tylenol, go back to sleep. But everybody has my cell phone number too, and so they can always call me if there's an issue. Yeah. Albeit in 8 years, I've had nobody abuse that. Yeah. Like, every time they called, I'm glad they called, and no one's taken advantage of that. In fact, I would say people don't call enough, honestly.
Yeah, I know. That you're like, why didn't you call me?
I would much rather be called too many times than miss the time when I wish you would call me.
Yeah, absolutely. Because we'd rather know, and then you can do something about it if you need to, or, help reassure. Because I always tell people, I don't want you at home, like, worrying about something, then just call and let me know.
Yeah. especially when it's, a quick 1 minute conversation could help you feel better about that.
Yeah. Some of the things that I feel like are different than whenever like I trained, and like your opinion of like the fat transfer and fat repositioning of the upper lid, because I don't do that.
Yeah.
What do you think about that?
Yeah. Let me review. I'll review a little bit of an anatomy. The upper, so we all know that you can get bags under your lower eyelids. You have 3 fat pads beneath your eyeball. You have a nasal, a central, and a lateral fat pad. And when we have, as we have more birthdays, sometimes that fat can become more prominent. People notice that as bags. Well, you also have analogous structures in the upper eyelid as well. We have a supranasal fat pad, a central fat pad, and then there's no lateral fat pad on the upper lid. That space is occupied by the lacrimal gland. That's what makes the tears that keep your eyes moist. But as we have more birthdays, especially the nasal upper inner corner, that fat pad can start to come forward too. And I think by and large, the paradigm has shifted in aesthetic surgery from just cutting out excess volume to preserving that excess volume and moving it to a spot where you need it. So for the upper eyelids, if someone has a really prominent nasal fat pad, but they've started to develop a hollow upper lid, you can see as patients age, sometimes they get that sunken appearance. You can take that nasal fat pad and just move it over, which I think is super useful. Just make a small buttonhole incision over the orbicularis muscle, get that fat pad, and then attach it to the central pad using a buried 6-0 nylon or 6-0 proline. And it looks really good in a lot of patients. Sometimes you just cut it out, but it kind of depends on the patient. I know people who do a really good job with filler to the superior sulcus. So that's that space above the eyelid, between the eyelid and the bone. If you are one of those people that's developed that hollowness or sunken in appearance because of birthdays and aging changes, I have seen really good results from that. In fact, I used to do it, and you could get really good results. I just, due to the unpredictability of filler, I've stopped doing that in my practice. I think most people, it doesn't give a big enough effect or a long-lasting effect to where, it's something I want to continuously use and keep in my toolkit. And then I've seen people graft fat, so harvest fat from the abdomen, spin it down, graft fat again to the upper eyelid, and I think occasionally it works great. Sometimes it gives the brow an appearance that might be pretty full.
Yeah.
But honestly, most people don't notice, I feel like, that big of a change with it. I feel like a lot of times that's one of those things where the surgeon can do it, and we say to ourselves, gosh, it looks great, but the patient's like, that didn't bother me.
Yeah.
So again, it goes back to that first thing we were talking about, which was teasing out from a patient what their goals of care are, and then just laying out the menu and letting them pick for it.
Yeah. My only experience with that has been someone that did have fat grafting there, and then it made it very heavy. And so I lifted the brow, but it was still heavy because there's still that fat there. And so it's probably my bias of like, ooh, I'm a little nervous about doing it, especially like laterally. I can see more like nasally making.
There are some spots that are certainly more forgiving. That spot in itself is not terribly.
Not so much.
Not
I wasn't in that
forgiving.
case.
Yeah, the cheeks, the zygoma, the great work with fat grafting. Some areas you have to be a little bit more precise.
And the fat transfer or fat, in the lower lid. So I will do fat transposition, but I do this really thin little layer, and I watch other people do it, and they take all of the bag and they transpose all of the bag. Which side of the fence are you on?
Well, I'll tell you what I found to work really well. I don't really debulk the fat that much. So I'll take all the fat that someone has, but the trick that I found is that you tease out those pedicles. So you take the fat that somebody has. I guess just to recap for some of the viewers who aren't familiar with what Angela and I are talking about, we tend not to often cut out the fat on the lower lids now in some demographics, typically, older females, if you don't want to hollow them out. So you take the fat that they have, and then you drape it along their bone to act like a natural filler, to use their native fat as a way to efface the eyelid cheek junction. So you get rid of the bag because you take out all the excess volume here, and then you put in the volume down here to give their cheek sort of a more youthful appearance, and then make a smooth slope from the eyelid to the cheek. What I've found is that if you take the nasal and the central pad individually and I use a 4 plain gut, so it's a dissolvable stitch. But if you take those and you make the pedicle wide and broad, as broad as you can, it gives the best contour afterward. And you don't really need to be concerned about the volume of the pad. The volume is what it is. It almost always lays down and settles just fine. So I haven't had an issue with that, having too much volume left over. But I have found that if you don't spread them out, then they can bunch up, and then you get a less than desirable effect. So my goal is always to make as wide and as broad of a pedicle as I can before externalizing it and then securing it into place.
Do you do the little stitch where it kind of pulls the cheek up a bit? I know I've seen people do that.
Yeah, it can. It just kind of depends where that cheek comes out. It doesn't always work out like that, but I make a pretty big pocket. Like I'll go a centimeter down below the inferior orbital rim because I want that stuff to lay in flat and really settle down nicely.
I feel like I'm always doing it with the facelift, so I'm like, oh, the facelift lifts it,
Yeah.
And so, but it looks cool. It looks very nice, when you can get that little cheek lift too.
Yeah,
and make that junction better.
That little extra lift, for sure.
So are there any of the trends that you're seeing that you don't necessarily like eye-wise?
Eye-wise. Well, I mean, filler, God bless filler. It's really solved a lot of problems. At least 20% of my practice now is migrated lower lid filler. It's probably it's the trend that I see the most. Now, granted, some patients are really great candidates for that. I don't do that. I don't do any filler. I let the experts in the filler do it. But a lot of people come to me because over time the filler starts to migrate, gets closer to the skin surface, and it actually accentuates the lower lid bag that was there before. And so you will dissolve it and then zero base it and then start over. So I would say in any given week, like I said, maybe not 1 out of 5, but at least 1 out of 8 patients is someone that's had filler that's moved or they want to readdress or dissolve and start over.
Yeah.
Do you see that much in your practice? I feel like not only does it get the lower lids, but sometimes it can also migrate out into the malar space, and then they may come to you talking about a facelift or.
Yeah, like the facelift, or then they're talking about like the malar shiners, because then it was either injected into that space or migrated into it, and that's tricky.
What's the longest you've ever seen filler? Patient says, I haven't had filler in X many years. There's no way it could be filler.
8 years.
Yeah, I had a 10-year patient.
Yeah, 10. Yeah, that you're like, there's no way. Yep. Yeah. There it was, like all in the muscle and everything else. And behind the septum, like in the fat where the bags.
Yeah. I do want to make it clear, I'm not anti-filler. Like, filler has a role. Just sometimes in the lower lids particularly, it acts up.
It can be a tricky place, and so you just want to make sure your injector does a lot of that, and they do it all the time, and because it can be tricky. It can migrate. Like that's where I feel like I see it migrate the most, even more than lips or anything like that. I see it migrate, and then it makes it look worse. Just not ideal.
Yeah.
But there's even people that I'll dissolve a few times, and there's still like filler there.
When you dissolve, you use hyaluronidase. Do you dilute it at all? Do you go in full strength, or how do you?
I go full strength.
Same.
Yeah.
In for a penny, in for a pound.
Yeah, if you're doing it, like
just do it.
Just go for it.
You don't want them to come back.
It's not pleasant either way. I might as well try to get it all.
Yeah.
I've dissolved for other surgeons that their patient lived here and they were going to have surgery, and so they asked me to like dilute it the way that they would, and so I've done it, but I like just doing it straight better. Wait,
so they were going to have surgery by another surgeon, and they asked you to dilute it
to dissolve it, and to dilute it the way they wanted it, and I was like, no, it's fine. It's your patient. I'll do whatever I want to do.
Oh yeah.
Just to save them.
If you know the surgeon.
I know the surgeon. I'll do it the way you want because they're going to be the one that's operating on them. Yeah. And just to save that patient a trip to wherever it was.
Yeah. That makes sense.
So tried it a different way, but I felt like it was way more swollen and puffy, and
if you dilute it.
Yeah, because you have all that saline in it. Yeah, I'd rather just be able to get rid of it in 1 or 2 goes. But
you set off a few alarms in my head. I guess I wasn't listening that closely, but like when patients come and ask you to do something like, hey, like let's do it like this, but like I want you to do it my way.
Yeah,
that's always tough because I'm like,
tough.
I only know one way to do it. If I had another way, I would offer it to you, but I can't.
Right, and if I thought the other way was better and that was something I was comfortable with, I would do it.
Do that with you.
Yeah.
Too.
Yeah, I've had that. They've done all the internet research, so much research, and they're like,
Right.
okay, I want it done this way. And you're like,
Which I support. I want someone coming in who's plugged in, who's
educated,
who's really proactive and says, hey, like I've done, this is what I know about it. Like, but, I can't change the menu. Like I can give you the menu and we got lots of options, but if I'm a barbecue joint, I can't serve you ramen.
right, it's not going to be very good.
Right.
I've had to have that conversation. Like, this is how I do it, and I know that I can deliver this if we do it this way. If I do it a different way, I don't know if I'm going to be able to deliver. It may be great. It may not be great. That's not how I do it all the time, and that's not how I would do it in you with your anatomy.
Each time, and I have been talked into doing a few things, which in hindsight, like I wish I hadn't. But each time it happens, I always regret it. I'm like, why didn't I just stick to my guns? Even if that means saying to the patient, hey, you know what? Like, here are two other names. Like, these are people I would trust. With my family members, like you could talk to them.
Yeah.
But with me.
Right. Yeah. Same. And it's usually like in the middle of doing it that you're like, why did I agree to this? Yeah. But I agree. I'll happily give them other people's names. Be like, just talk to them, And I think there's a lot of things that's confusing out there now for us. Is like, okay, if they look, because I've had people that were so set on this technique, because they saw that this was done with this technique. And I'm like, well, that was done in that patient with that technique with that doctor. It doesn't always translate the same, and I, like you said, appreciate you being very involved in this and like looking this up, but I wouldn't get so caught up on which technique it is,
Yeah.
Also, like if someone's put it on Instagram, what they say and what they really did, you cannot believe everything on Instagram.
No. Unfortunately.
Yeah, there's a lot of stuff, like, well, that's probably, you can look at the picture and it's probably not how it was done.
We're lucky to be in Houston. I feel like there's such a huge medical community here and so much people are doing good work where I have a whole group of people where if I'm talking to a patient and I don't quite think that we're on the same page, I always give out 2 or 3 names. I'm like, hey, why don't you talk to this person, this person, or this person? I would trust them with my eyelids, like just see what they say. And then we can always reconvene, or you might find out that you have a better vibe with that person, which is important. Like, you gotta, if you don't feel like you click, you gotta find somebody you click with because it's a process. And,
absolutely. And you want to be comfortable that you're going to be able to ask the questions you need to afterwards and be able to communicate with them and say, what about this or what about that? Not feel like, oh, I don't want to talk to, ask them or hold back for whatever reason.
Yeah. You want them to feel 100% comfortable with you. And it's kind of like, you're going on an expedition and you need like an expedition leader, like a tour guide or something. Like my job is to take you on this expedition, show you the sights, but like also make sure you're safe.
Yeah.
Right? Like we can't go into that part of town, but we can go into this part of town.
I've been there.
Right.
You don't want to do that. Right. Let's go this way.
I know. Yeah. When I have these conversations with patients, I feel like I block off an hour for my consults, and I should shorten that down. I just, I got the gift of gab from my mom, so I end up talking to them a long time, and
it's a good thing.
We cover a lot of territory.
Yeah,
but it does help me weed out the ones that I feel like I don't jive well with.
Yeah,
or that don't jive well with me.
Right, because it's a relationship, and so it needs to be good, on both ends. Yeah. And I think it's good to take that time because you get to know them, they get to know you. You make sure the bullseye is aligned of where you're going.
Yeah,
I think it's time well spent.
The bullseye, I like that. I'm gonna start using that.
Okay, I got the birthdays from you.
Yeah, because you've had more birthdays.
Yeah.
Patients always. So she's saying, I tell patients, like they'll ask me like, well, do you see this? And oftentimes they'll say, I do see that. Like, well, what caused it? And I'm like, well, sometimes, the more birthdays you have, you're prone to that happening, which is true. Like as we get older, there are certain aging changes, and it takes some of them like a minute to be like, birthdays. What is he? Oh, he means, okay, I got it.
Yeah,
right.
I'm sure it lightens the mood too, where they're like, bit. Oh yeah, haha, that's funny.
Bit. You got to have a few jokes in your back pocket because you're only talking to a lot of these patients for not that long a time, so you got to, you got to put on a show.
Well, and they're nervous, and I think it helps whenever you can kind of lighten the mood a little bit because they're super nervous. Yeah. It's their face. They've been probably thinking about this a long time.
Yeah. When I was in medical school, I tore some cartilage in my hip. It was an overuse injury. I had it was my right hip, and I injured it while I was running. And I tore the acetabulum, which is like a piece of cartilage on the top. And at that time, not many people in the country were doing hip scopes, like scoping the hip to repair it. But there were only like 3 people. And I got on the wait list and got in, and I had surgery with one of the guys who was really proficient, and everything turned out great. But it was the best experience I had in medical school because I learned what it's like to be the patient. I learned, but you go back and you revisit it. Like you spend so much side on one part, you spend so much time on one side of the aisle that you forget what it's like to be the one with the gown on in the operating room bed. And I think it gave me a better sense of like how much gratitude you can have towards someone who spent his or her life like getting good at a certain surgical technique. And then also like how scared patients can be sometimes.
Yeah.
You know? I think that a lot of times it's easy for doctors to get calloused and forget that because you spend so much time delivering care, you don't have the perspective to know what it's like to be on the receiving end. And that was my 3rd year of medical school, and honestly, that was just as valuable as any class I took when I was in med school.
Yeah, I think it's important to keep that in mind of like, this is a normal Tuesday for you and for me, you know.
Yeah.
The anesthesiologist doing their normal job, but this is like a life event for that person.
Yeah.
You know, it's a big deal. This is something they will always remember and be like, well, in, 2014, I had whatever surgery. They will remember, it's a big deal. Well, thank you for taking your time and being with us and sharing your perspective. It's always fun.
Let's do it again.
Yeah, for sure. Awesome. Well, if y'all liked it, share with your friends and family, subscribe, and you can find Dr. Hamill at your website.
My website, it's just Dr. Eric Hamill. Is it Dr. Eric Hamill? No, it's Eric, scratch that. It's my name, EricHamillMD.com. You can tell how much time I spend on my website, just EricHamillMD.com.
It shows you... Pretty much all of his patients are for word of mouth. So if that tells you what a good job he does with every single patient, it's pretty phenomenal. You can find me at drangela.sturm.com, and then the podcast on wherever you get your podcasts, Apple, Spotify, any of your favorite ways. Oh, thanks for watching.